Thank you everyone for joining us today for the Autumn 2021 Michael M. Davis Lecture Series. Please check out the CHAZ website as we add the lineup for the Spring 2022 Lecture Series. In a moment, today's discussion moderator, CHAZ Director, GFAP Co-Faculty Director, and Crown Family School Professor Jean Marsh will offer brief opening remarks and an introduction of today's presenter. Assistant Professor of Sociology at the University of California, San Diego, Danielle Raudenbush. If you have any questions, please type the questions into the Zoom Q&A pane or the chat function. Doctors Raudenbush and Marsh will try to address questions following the slideshow and the presentation. A recording of today's webinar will be available on the CHAZ YouTube site, which can be found by searching for Center for Health Administration Studies on YouTube. And we post most of our content on our website as well, which is chaz.uchicago.edu. And now Professor Jean Marsh will introduce today's presenter.
Good afternoon. It's my pleasure today to welcome you to today's Michael Davis lecture and our lecturer, Danielle Raudenbush. Professor Raudenbush received her BA in Sociology and Hispanic Studies from Vassar College and her PhD in Sociology from the University of Chicago. She's broadly interested in questions related to social cohesion among low-income minorities and the role that people's social relationships play as they cope with material deprivation. Her research centers on questions that are fundamental for understanding health and well-being of minorities and low-income people in the United States. She uses qualitative methods to examine the healthcare practices of the urban poor, and specifically the informal network strategies that low-income African Americans develop in attempts to treat health problems when they face barriers in accessing formal care. And in the small world category, I have to note that Dr. Raudenbush's late mother, Stella Raudenbush, was my daughter Lee's very favorite teacher at the University of Michigan. Lee participated in a program, Lucy, Lives of Urban Children and Youth, that Professor Stella Raudenbush organized and developed, and it made a big difference in the experience of my daughter at Michigan. So without further ado, please join me in welcoming Dr. Danielle Raudenbush, who speaks to us from her recently published book, Healthcare Off the Books: Poverty, Illness, and Strategies for Survival in Urban America.
All right, thank you so much, Jean, for the invitation and also for that nice introduction. Thank you, Keith, for organizing everything. So as Jean mentioned, the lecture, my lecture for today is titled Healthcare Off the Books: Poverty, Illness, and Strategies for Survival in Urban America. Now, the study that I'll be presenting from this book, which was published in 2020, is part of kind of a larger research program that I have in which I investigate kind of the broader question of how the healthcare system functions in practice for low-income minority groups, right? So as I'll get to it in a minute, in the book, I examine this question as it relates to low-income African Americans, and you can see the cover of the book right here. I'm also conducting a new study in which I examine this question in relation to Mexican immigrants who live in San Diego, California. And right here, you can see a reference to a paper that I recently published kind of on this topic in social science and medicine. But for today, I'll be focusing on this book project. So the primary kind of research question or kind of sociological puzzle that guided my work in Healthcare Off the Books arose out of two well-established findings in research on health disparities and access to care. So the first is that African Americans, and especially low-income African Americans, have worse health on average compared to others. And this exists across many health measures. The second is that access to care is highly unequal, and that low-income racial and ethnic minorities have less access to health services than others, and this includes African Americans. Right, so these two findings point to an important tension between kind of medical need and then access to care, and give rise to a question that I think is really kind of fundamental to understanding the health and well-being of the African American population. And this is the question you see here on the slide. So if people are sick and have difficulty accessing health services, what do they do to treat their health problems? Okay, so this is the question that kind of guided my work throughout kind of the research I conducted for this book, throughout the writing of the book. Importantly, it's also a question that has largely been overlooked in existing scholarship. So to examine this question, I conducted fieldwork in a predominantly African-American public housing development that I call Jackson Homes. That's a pseudonym, but I call it Jackson Homes. And most of this fieldwork was done between 2010 and 2013. It consisted of participant observation at kind of community events and informal gatherings within Jackson Homes. It included two focus groups with residents of Jackson Homes. And then I also conducted 43 formal interviews with residents of Jackson Homes. In addition to fieldwork in Jackson Homes, I also interviewed 17 doctors who either work with residents of this housing development or who work with other low-income Black communities in the city in which Jackson Homes is located. So that was kind of the bulk of the field work that I did. Importantly, in 2014, the Patient Protection and Affordable Care Act was implemented. So I returned to Jackson Homes and I conducted additional follow-up interviews in 2015 and again in 2016. Okay. So when we think of this question of how low-income groups like the Black urban poor manage their health problems, we can see that there are three kind of dominant explanations in existing scholarship and kind of in public discourse, right? So the first is this idea that people belonging to this group get care through facilities like community health centers or public hospitals, right? And this is the idea essentially that there are kind of two healthcare sectors in the US, and that low-income people who are kind of Medicaid beneficiaries or who are uninsured depend on the healthcare safety net, while others get care kind of largely through a private healthcare sector, right? So that's the first explanation that we commonly hear about. The second is that people in this group rely on emergency departments. And importantly, this is not only in cases of kind of medical emergencies, but also for routine care, right? So this is the idea that when people don't have a usual source of care, they wind up turning to emergency rooms. And then the third explanation is that when people are unable to access health services in places like hospitals and clinics, they kind of turn to cultural practices. And this includes things like the use of herbs, folk healers, home remedies, and then especially among African Americans, kind of religious practices like prayer. Okay, so those are the common explanations that exist out there. Now, what I propose in the book is something different. And specifically what I found while I was doing research in Jackson Homes is that while many residents do at times get care through facilities like public hospitals or through community health clinics, it's often difficult for many of them to kind of get continuous care through these facilities. And so in response, what they do is they use several kind of informal strategies to treat their health problems. Importantly, though, these are different from the informal cultural strategies identified in past research, okay? So specifically what I found and what I argue is that people get care through a kind of formal, informal, hybrid healthcare system that has several key features, okay? So the first is that kind of within the system, people who face obstacles to care get care through their social network ties. Okay, and specifically, they obtain kind of a variety of health-related resources through their social network ties. And these include things like pharmaceutical drugs, medical equipment like canes, walkers, wheelchairs, nebulizers, and then also health insurance cards. Now, second is that people's ties to individuals that I call intermediaries are key to obtaining these resources. And what I mean by intermediaries here are individuals who have access to or kind of a connection to hospitals and clinics, either as patients or employees. Okay, so the idea here is that kind of through their connection to hospitals and clinics, these intermediaries are able to perform an important function. And this is to act as informal resource brokers. Okay, and what I mean by this is that because they're connected to hospitals and clinics, because they have access to these healthcare facilities, they're essentially able to kind of informally distribute health-related resources to people who face obstacles to care. Okay, and as I'll show, they do this in ways that kind of tend to violate the rules, regulations, and kind of norms of the formal healthcare system. Okay, and the intermediaries I'll discuss include doctors, friends and family members of care-seeking individuals, and then a group of people that residents call kind of street entrepreneurs or street pharmacists. Okay, so this is just kind of a visual depiction you see here. On the left, you see the formal healthcare delivery system. Within this system, you have a set of rules and regulations and norms about things like who has access to this formal system and how resources are to be distributed within this formal system. But then you've also got intermediaries, right? People like doctors and patients who are essentially distributing health-related resources outside of the formal healthcare system to people who face obstacles to care. Okay. So this is really kind of the main point that I make in the book, is that kind of the way the healthcare system functions in practice for people like residents of Jackson Homes is very different from what we commonly imagine, right? It doesn't only kind of involve getting care through this formal healthcare delivery system. Instead, it includes this formal system, but then it extends into an informal social realm where health-related resources are distributed informally through people's social ties. Okay, so that's the kind of the central argument in the book. A little bit more about Jackson Homes. It's located in a US city. It has approximately 2,000 housing units. It's predominantly African American. Kind of by definition, it's characterized by concentrated poverty. So all residents within the development are low income. It's located in an environmentally hazardous area with kind of highly toxic industries close by. And then additionally, it has high rates of illness compared to many other communities in which the city is located. So these include, for example, kind of elevated rates of low birth weight babies, elevated rates of lead poisoning, higher rates of death by chronic respiratory disease, heart disease, stroke, and diabetes related death, among others. Okay, so that's just kind of some contextual information about Jackson Homes. All right, so what does access to care look like in Jackson Homes? So access to care in Jackson Homes actually varies. So there are some people, some residents who are kind of very integrated into the healthcare system. They have primary care doctors. They kind of don't face obstacles to accessing care. But then there are others who kind of face considerable obstacles to accessing care. So in the book, I kind of spend a lot of time discussing why this heterogeneity exists, kind of what this heterogeneity and access looks like. For the sake of time, I'm not going to go into that here. But one thing I want to point out is the fact that there are some people who do have access to care in this community, while others do not, is kind of important for the co-construction of this formal-informal hybrid system. Okay, so what we see is that in this community, there's both kind of a supply and demand for health-related resources. Okay. Now in the book, I also kind of describe in detail the various obstacles to care that some residents face. Again, for the sake of time, I'm just going to kind of go over these briefly. So many people that I met in the development were uninsured. This was kind of particularly true before the implementation of the ACA, but it was also true for some even after the ACA. Without insurance, it was hard for them to kind of pay for the various out-of-pocket costs associated with getting care. And this was even in safety net healthcare facilities. In terms of income, all residents of the development were low income, as I mentioned. Among the study participants I formally interviewed, all but 2 had a reported annual income of less than $10,000 per year. The other 2 had incomes of less than $24,000 per year. Many residents, including kind of the participants that I interacted with, don't have cars of their own, and then paying for public transportation can sometimes be difficult. So this often kept people from being able to kind of get to and from the various healthcare facilities, right? Many people reported distrust in healthcare providers or in the healthcare system more broadly as being a reason for why they didn't access care. Others also cited past experiences of mistreatment as keeping them from seeking care. And then one obstacle I want to talk about a little more, because I think it's something we haven't really seen in past research, is this idea that I developed called linked health fate. So as I mentioned a minute ago, Jackson Homes is located in an area that has kind of elevated rates of poor health. And because of these elevated rates, there's this kind of common narrative that you hear among residents about the health of people in the community. So in this narrative, people kind of see their own health as linked to the health of those around them, and they assert 2 central claims. First is the idea that many people in the community are sick with serious illnesses, and that such illnesses can potentially affect anyone who lives there. Second is the idea that these illnesses are the result of the environmental context in which they live, right? So people believe kind of that the air they breathe, the water they drink, kind of the buildings in which they live are all kind of poor quality, hazardous, and thus health damaging. So what we see in Jackson Homes is that residents kind of see other people around them getting sick. They attribute this to the context in which they live, and then they become fearful about their own health. And then this fear winds up essentially becoming an obstacle to getting care, because people are worried that if they go to the doctor, they're going to learn that they also have a serious illness, right? So they essentially avoid getting care because they don't want to learn that they're sick. So this idea of linked health fate is a kind of cognitive obstacle that arises from a particular kind of community and environmental context, okay? So those are kind of some of the main obstacles to care that people in this community face when trying to access care. So if residents aren't getting healthcare in places like hospitals and clinics, what are they doing, right? What are they doing to manage their health when they become ill? So first, I'm going to present some examples from interview data from the pre-ACA period. Okay, so I'm going to begin first with a participant called Teresa. So when I met her, Teresa was 23 years old. At that time, she was unemployed and she had a young child. So because she was the primary caregiver of a minor, she was able to receive Medicaid. Teresa is someone who uses her insurance status to help her uninsured friends and family members. So in this case, or in this sense, she acts as an intermediary. So in an interview, when I talked about her recent healthcare experiences, when I asked her about them, Teresa explained that she had recently gone to the doctor to get the morning after pill. She explained, however, that the pill wasn't actually for her. This is what she said. It was for my sister because something's wrong with her medical card right now. So I went up there and got one for her to use. So Teresa went on to explain that her sister had recently kind of lost her insurance. She had become ineligible for Medicaid when she lost custody of her kids. So at that moment in time, she was uninsured. Teresa explained that her sister and her sister's boyfriend had kind of made a quote unquote mistake. And in an effort to help her sister avoid an unwanted pregnancy, Teresa went to her doctor and got the morning after pill for her. Okay. So I asked Teresa if she helps her sister like that a lot. And this is what she said. She said, I do it a lot. I do it for a couple of my friends too, that's not on medical, meaning that they don't have insurance. Like sometimes they ask me, I need this medicine or I need this, and they can't get it. They have to pay and they don't have the money. So I just go sit at the doctor with them sometime, or I might sneak and let them use my medical card. So what we see in this case is that Teresa's friends have difficulty accessing care because they don't have insurance and they can't pay the out-of-pocket costs for care. As a result, they turn to Teresa for assistance. Sometimes Teresa gets medicine for them herself, like in the case with her sister. Other times she checks into a clinic with a friend. She'll present her card at the front desk, and then her friends proceed to see the doctor. Other times, Teresa will give her card, her insurance card, to a friend and will let them visit a clinic on their own using her card. Okay, so that's the case of Teresa. Another example is Jamel. So Jamel was 29 years old when we met, and he had experienced severe headaches for years. In an interview, he explained to me that one day while he was working at his seasonal construction job, he had fainted. His workers called an ambulance and he was taken to the hospital where he was admitted and stayed for 12 days. So while he was there, he underwent multiple exams, including a spinal tap, several CT scans, and an MRI. He explained to me that doctors told him that he had a quote unquote infection in his brain. So during his stay at the hospital, doctors gave him antibiotics to treat the infection and painkillers to treat the headaches. When I met Jamel 2 years after this incident, he was still experiencing headaches that were at times kind of so bad he was unable to get out of bed or leave the house. Despite the ongoing pain and the seriousness of his symptoms, he had not been back to see a doctor. One reason being that he didn't have health insurance. When I asked Jamel what he does to treat his health problems, he explained the following. I take Excedrin and stuff like that, just regular pain pills, or I got a little brother that he's on Medicaid and he'll get the infection pills for me because I know what to take, so he'll go get the penicillin or antibiotics for me and I'll take those. Later, he went on to explain that he also sometimes buys antibiotics and painkillers off the street in the underground economy that exists in this community. And he buys them from people that residents refer to, as I said a minute ago, as kind of street entrepreneurs or street pharmacists. So he explained, people goes and get them from the doctor just to sell. If I see them and they ask, do you need, I got Vicodin or I got penicillin, what you need? And if I don't got it at the time, I buy some from them. I do it every time I see them. Every time I can catch them, I'll buy them because that's good medicine. Okay, so in an effort to kind of manage these severe headaches that he has, Jamel tries to replicate some of what the doctors had done to him in the hospital, right? So he sends his younger brother who has insurance to his doctor to try and get medication. When his brother's unable to do this, Jamel kind of turns to buying it off the street, right? And he thinks that this is kind of the correct thing to do because in the hospital, they were giving him pain pill and antibiotics, right? So he's trying to kind of continue to do that to manage his headaches even 2 years later. So in addition to medication, people buy and sell medical equipment in the underground economy in this community. So Johnny, who was a lifelong resident of the development, explained this. He said, you see that people are able to get walkers, canes, this and that. You ask them, you gonna get this? I'll give you a couple dollars, because that's the way it is. Everybody that's out here is into it. There ain't no shame in it. Just go and make a deal. People tell me I sold so-and-so a cane the other day because they was limping. They said their side was hurting real bad, so I sold them my crutches. Okay, so what Johnny is explaining here is that kind of the buying and selling of health-related resources on the street is a common occurrence in Jackson homes. What I learned while doing research there is that the health-related resources that residents sell are oftentimes kind of things that they have gotten for their own purposes. So someone with asthma might sell their inhaler, for example, or someone might get antibiotics. They'll take the antibiotics for a few days. They'll begin to feel better, and then they'll wind up selling the rest on the street, right? Or to kind of other people in their community. Other times, there are some people who kind of go to the doctor to get items specifically to sell and kind of as a way to generate income. Okay. So far, I've mostly highlighted participants who were uninsured. Importantly, however, even some people with insurance at times kind of use ties to friends and family and street pharmacists to access health-related resources. So Georgette was one such person. So Georgette has asthma and has suffered from serious back pain since she was injured in a previous job. She's had Medicaid for years, and at one time she was required to pay a co-payment for some of her medications. In an interview, I asked her whether it was ever difficult for her to get medicine, and she responded with the following. She said, "Sometimes I used to have a co-payment, and if you don't have the money, you can't get your medicine. So it's a lot of times I couldn't get my medicine." I asked her what she would do in those instances, and she said, "I would have to borrow money and get either an Advil or my mom. My mom was my pharmacist for a long time. She would give me her pain pills." And there she's talking about kind of prescription strength ibuprofen. And then she says she had asthma too, and she would give me one of her asthma pumps. They'd give her 4 or 5 pumps, and she would give me one of her pumps. Okay, so what we see in this example is that the use of ties to intermediaries in this community is not limited to the uninsured, right? Here, Georgette turned to her mom because of kind of the cost of co-payments, even though she had Medicaid. Other insured residents I met kind of used their social ties in these ways because of things like distrust in a healthcare provider or kind of in the healthcare system. Some people did this just because they found it to be easier than kind of trying to navigate getting a doctor's appointment, getting to the hospital or clinic, or getting to the pharmacy, right? So it's just kind of a more convenient strategy. All right. So the examples I've given up until now are from before the ACA. Now, what about after the ACA? So as most of you probably know, the Patient Protection and Affordable Care Act was implemented in 2014. And at that time, in many states, Medicaid eligibility was expanded, right? And this included in the state where Jackson Homes is located. So what this meant was that all of a sudden, many of the people who were uninsured in Jackson Homes became eligible for Medicaid, right? So this change in legislation raised important questions for me, like, for example, were the uninsured people I had met in Jackson Homes actually becoming insured? And were people still engaging in the strategies that I had kind of previously identified? So with these questions in mind, I returned to Jackson Homes in 2015, and then again in 2016 to kind of try and see what was going on. What I found is that some people I had previously met had indeed become insured and had indeed become kind of integrated into the formal healthcare system, right? So they had a usual source of care, and they were kind of managing their health and their health problems through formal channels, right? However, there was also evidence that the hybrid system and kind of the use of ties to intermediaries to get health-related resources was enduring, okay? So let's consider the case of Claudia, someone I interviewed in this follow-up period. So Claudia is someone who has been what they call dually eligible for years, meaning that she was covered both by Medicaid and Medicare. So this was because she was kind of both low income and because she had a severe chronic respiratory disease, which was considered a disability. So with her insurance status, Claudia is kind of very integrated into the formal healthcare system. She has a primary care doctor she sees regularly. She sees several specialists on a regular basis, and she reported no difficulty accessing any aspect of care. Okay, so in a follow-up interview, she explained that she obtains various types of medication and medical equipment from her doctors, and because of her condition, these resources are actually delivered to her home, right? So this includes items like albuterol inhalers, liquid albuterol, nebulizers, as well as kind of insulin and other medical equipment to manage her diabetes. Sometimes Claudia actually has more medication and medical equipment than what she actually needs. In these instances, she explained to me that she redistributes it to other people in her community. She explained, like I said, that medication comes to my home by the boxes and cases. I mean, if I can help somebody, I can help them. It's already paid for. Medicaid pays for that stuff. I've had sick people ask for my inhaler. For example, my friend Rhonda, the other day I gave her an inhaler, and that's only because I had 2 new ones, and I already had one in my purse that still had 100 and some puffs on it. She went on to explain, most people come for my insulin and like needles. Like I say, I'd be getting that stuff. I would never give nobody pills. I don't do that. Insulin if you want, and lancets. Okay, so again, this was after the implementation of the ACA, right? So why are people still using intermediary ties to get health-related resources even after Medicaid has been expanded? Well, there were various reasons that I kind of identified. First, I learned that some people were not successful in applying for Medicaid. So some people had difficulty kind of getting all of the different kind of documents you need to apply together. So they just didn't have the paperwork to be able to apply. Some people applied, but they were denied. They didn't really know why, quite possibly because they didn't submit the correct paperwork. But they were denied, and then they kind of thought, oh, that must mean I'm not eligible. So they didn't apply again. Other people had gained insurance, but then it lapsed because they didn't fill out kind of the required annual redetermination application. And some people I talked to said that they didn't want the government to have their private information, and so they just didn't even try to apply. And then when we're thinking about kind of why these strategies are enduring, we need to also remember that there are kind of attitudes and perceptions about healthcare that keep people from seeking care, right? So it's not always about insurance. Instead, it's kind of about these attitudes and perceptions, right? Having to do with distrust, having to do with past experiences of mistreatment, and then also this idea of kind of linked health fate that I presented earlier. Okay, so there was evidence from after the ACA that this hybrid system kind of continued to exist. Now I want to just take a brief moment to talk about the local community context. So this is something I kind of describe in depth in the book, but it's essentially kind of how the local community context shapes people's healthcare strategies, like the ones that I've just described. So the local community context matters, right? So in Jackson Homes, one of the things that I learned is that people exchange a wide range of resources. These include items like food supplies, transportation, money, childcare. They also buy and sell a wide range of goods and services in the underground economy that exists there. So one of the things that I argue in the book is that these network strategies and kind of the existence of the underground essentially wind up forming the infrastructure upon which people people develop their healthcare strategies. And these kind of existing network strategies in the underground economy really kind of shape how these strategies are carried out. So again, I'm not going to go into all the details there, but it is kind of the point here that I want to make is that kind of the local community context is important for how people like Jackson Homes residents kind of manage their health problems, right? It winds up influencing how they interact with the formal healthcare system. All right. So as I mentioned earlier at the beginning, I interviewed 17 doctors about their experiences working with low-income Black urban populations. And here's a quote from one doctor that came at the end of an interview with him after I had kind of explained what I had been learning in Jackson Homes. And what he said to me is that he has patients who engage in some of the very same strategies that I had learned about. He said, if they need their medicine, if they need their medications, and I'm talking about everything from Zantac to aspirin to their high blood pressure medications and to their antipsychotics, they can get it on the street. They can tell you who they need to go to and what they need to order. They'll turn around and say what type of cane you need. I can get you a cane. I can get you this and some other stuff too. The system is there. It's set up. Okay, so this doctor is well aware of the strategies that I had identified in Jackson Homes. Interestingly, this particular doctor actually worked on the far side of the city from Jackson Homes, which kind of indicates that these strategies are present in other communities as well. Now, importantly, of the 17 doctors I interviewed, 10 engage in kind of a set of various kinds of informal assistance strategies to help their low-income patients, okay? And in this way, kind of through these informal assistance strategies, they help to create the hybrid system. Okay, so I'm gonna present a couple examples of this. So Dr. Lawrence was one such doctor. He explained, I won't say we got caught, but we've been told we're not supposed to do this. It's like, are you serious? We actually had medications that patients did not come back and get. This is in the clinic pharmacy, but brand new bottles that other patients can use until their medications can get started. And somebody came doing a check and they took them and dumped them. So yes, we've utilized stuff like that. So we're just, I call us an additional free pharmacy. So Dr. Cook, a doctor in her 30s who works at a community health center, also sometimes helps her patients kind of informally, and by informally, again, I'm talking about kind of in ways that violate existing rules and regulations of the formal healthcare system. So she explained, we have some medications that I'm not sure what grant money was used to purchase them, but it's for a homeless program, and our homeless program isn't going on right now. But we still seem to be getting shipments of these medicines. So we have it, and I'll use that medicine for people. Like, I do it very rarely because I'm not supposed to do that. But I'm like, this person needs it. There's no way this person's even going to be able to get to the pharmacy, you know? And then one final example is Dr. Sampson. She said, you know, a lot of times I would give patients money. If they said, look, I don't have $5 to pay the copay, I'd say, here's the $5 and please just go and get your medication. Okay. This particular doctor also explained paying for things like transportation for patients. This doctor even once paid for a hotel room for a homeless patient who had just been put on oxygen. This homeless patient couldn't get into a shelter, so they didn't have any way to kind of plug the oxygen in. So the doctor actually paid for a hotel room so that this patient could use oxygen. Here's a list of some of the informal strategies, assistance strategies that doctors use. So they give patients medication from unauthorized stashes. And in this, you know, I'm talking about things other than kind of samples from pharmaceutical companies. They do things like write prescriptions at double the dose of what patients need. The patients can then kind of cut the pills in half and get more medication for the same price. They give patients money out of their own pockets to pay for medication, to pay for appointments, to pay for transportation. As I said, someone paid for a hotel room. I also heard about doctors paying for things like microwaves for their patients when they were worried they weren't getting enough to eat, kind of other items like that. And then a couple of people even reported writing prescriptions for uninsured patients with the name of an insured family member so that that person could get medication for a cheaper price, for a lower cost. Right, so an important question to ask is, why are doctors motivated to assist their patients in these ways, right? Especially when the strategies that they use, or at least some of them, could actually put them at professional risk. So in the book, I described kind of many factors that influence doctors to do this. But one of the central factors is because doctors that work with this population experience an intense kind of goal resource conflict, right? So the doctors I interviewed kind of talked in depth about being driven by this ethos of wanting to treat each patient to the best of their ability. For them, this ethos kind of shapes their interactions with all of their patients, right? So they're just kind of highly motivated to follow this ethos. But then they also explain that at the same time, they face significant resource deprivation within their work environments. So here's a nice quote from Dr. Sampson. She explained, in a low-income setting, on the patient side, they don't have all the resources that they need or that you and I would have to get what needs to be done easily. So it's a lot more work and effort. And then on the organization side, like on the clinic side, we were also limited in what we could offer our patients because we're in the same situation together. She goes on to explain kind of how they're limited in resources within the clinic. And then she went on to explain, I wish I had specialists who were able or willing to see my patients. I don't. I would have to sometimes call around and beg specialists to see my patient. I know you don't take Medicaid, but this person doesn't have anywhere else to go. And if you don't see them, they're going to have a heart attack or they're going to lose their sight. Okay, so what this quote kind of illustrates is that there's significant resource deprivation in their work environments that kind of operates on multiple levels. It's present within the kind of patient population in terms of things like insurance status and income. It's present within the facility or kind of the organizational level. And then it's also present in terms of things like the professional network level, right? So Dr. Sampson went on to explain kind of the conflict she experiences because of this deprivation. She said, the biggest challenge that I always talk about is just, I'm a doctor. I went to med school. I know what to do. And when I have a patient in front of me, I know the steps to take to get the information from them, to do a physical exam, to run tests and come up with a diagnosis, and then prescribe medication or some other type of therapy to treat. But I can know everything I'm supposed to know, and it just doesn't sometimes translate when the patient doesn't have the resources. Okay, so when we're thinking about kind of this question of why doctors are motivated to kind of informally assist their patient by giving them medication from special stashes, by kind of giving them money out of their own pocket and so forth, we need to kind of understand this intense goal resource conflict that they experience. So the informal assistance strategies that they use are essentially kind of an attempt to remedy or kind of to address this goal resource conflict. Okay. So what are some of the main kind of takeaway points from this? So the main argument I want to make here is that kind of care-seeking individuals that face obstacles to care and the intermediaries that help them, they kind of fundamentally transform the nature of the healthcare delivery system in the US. And specifically, they co-construct a kind of formal-informal hybrid system, right? So this hybrid system involves kind of the formal or kind of institutionalized aspects of the healthcare delivery system, right? So this includes things like hospitals and clinics, the kind of legal and official roles of people who participate within these facilities, including doctors and patients, and then the rules, regulations, and kind of norms that determine how healthcare is delivered and who has access to health services, right? But then what we see is that it also includes, this hybrid system also includes an informal set of behaviors that involve the distribution of health-related resources through people's social ties in ways that violate the norms, rules, and regulations of the formal system. So that's one of the main points, right? Another thing that I argue is that if we want to understand kind of the health and well-being of low-income groups like residents of Jackson homes, we need to kind of recognize this hybrid system, right? So by recognizing it and kind of understanding it, we gain new insights into sources of social and racial health disparities. So a couple of points on this. So I didn't measure the health effects of kind of using these strategies, right? But I think we can kind of hypothesize about some of them. So some of the behaviors I've described, such as when doctors informally assist patients, right? We can see that that might have a potential to have kind of a positive impact on people's health, right? Because doctors have the medical knowledge that they can draw on when they're kind of informally helping their patients, right? But if we think of instances in which people are kind of getting things like medication and medical equipment from friends and family or off the street, like it can clearly have negative health effects, right? So people who do this are largely treating their health problems kind of outside of the purview of medical professionals, right? This means that, for example, serious health problems may be overlooked. It means that people may be kind of misusing medication, right? Which can actually make them more ill, right? And so in this way, kind of some of the healthcare strategies that I've described actually have a kind of negative compounding effect, right? So people who are already disadvantaged because they aren't able to access health services are kind of further disadvantaged when they use the health strategies, some of the health strategies that I've described. Another kind of related point is that when people are kind of relying on ties to intermediaries to manage their health problems, to treat their health problems, healthcare becomes something altogether different from what it would be if they were integrated into the healthcare system, right? So they're not getting preventive care. They're not getting access to kind of labs and various kinds of medical exams and so forth. Instead, healthcare becomes kind of largely reduced to using whatever resources are available, happen to be available through their network ties, right? And then one final point is that I think that this book helps us to understand how to build, to kind of begin to think about how to build a more equitable and just healthcare system. So the study more broadly kind of helps us do this by describing, for example, kind of different obstacles to care that people like residents face that haven't been recognized in past research, right? So we can think here about kind of linked health fate. It also does this by, again, kind of, for example, by detailing in depth some of the challenges doctors who work with this population face and what they have to do to kind of overcome these challenges, right? So we can draw on these kinds of insights to think about how we can kind of better integrate low-income African Americans into the healthcare system and kind of how to improve the work environment for healthcare providers who work with this population. All right, so I'm gonna go ahead and stop talking there, but I'm looking forward to some questions.
Thank you, Danielle. Thank you very much. You've given us incredible insights into our healthcare system and understanding it. We have some questions in the line, but I would just like to start out with questions about these obstacles you talk about in our healthcare system. When you start looking at our entire system, I often say to students that in terms of if you're doing a healthcare intervention, transportation might be the best intervention you could include in your services. And this, along with income, along with insurance, all of those are very important healthcare interventions, as you've pointed out. What I guess we should know that as researchers, certainly, but I'm very interested in what are the lessons for our training of doctors, nurses, healthcare providers, people who are shaping the system.
Mhm.
Can you reflect on that for a minute?
Sure. Well, I mean, I think, when we're thinking about what the obstacles to care are here, in relation to your question, we have to be thinking about this issue of distrust, experiences of mistreatment, and so forth. And I think our medical school training needs to do a better job in terms of cultural competence, right? So from what I've read, there's a researcher at Temple who graduated from my department a few years ago, Lauren Olson, who's looked at this issue of kind of cultural competence training within medical schools. And what she found is that oftentimes it's kind of marginalized within medical training. It's not delivered in a formal setting. It's frequently delivered in kind of small group settings. Doctors rely a lot on kind of anecdotes provided by students of color instead of having a formal curriculum, right? So I think that we need to rethink this, how cultural competence is taught within medical schools. It needs to be centered within the curriculum, I think, and it needs to be ongoing. So not reduced to a module or two, but something that is ongoing, and then also is ongoing even past medical school, so that doctors have kind of continued training on this issue even after they're working as professionals.
Great, thank you. I will state a question for Irene Ziaya. I'm a social worker in healthcare, and for years heard that uninsured patients could get care from MDs who just took minimal cash payment and received meds in ways you described. My question is, how do we quantify this problem? What are other solutions do you dream about? Or is this really a problem, I would ask?
Mm-hmm. Yeah, so I think that this study can be used to develop additional studies where we are kind of systematically investigating the extent to which people kind of beyond this community are using these kinds of informal strategies. Right now, we know that they exist. Now we need to understand, kind of more statistically speaking, what is how frequently are they used, who is using them, and so forth. Right. So I think that's one thing. Another thing, I think part of it was my dream solution. There are lots of kind of dream solutions. I think, when we're thinking about these minimal payments that exist at safety net healthcare facilities, what I found is that even very small payments can keep people from getting care, right? And this is because people are cash poor. They do not have cash on hand, or they only have cash for part of the month, right? And Kathy Eden and Luke Schaefer wrote a book called $2 a Day. What they found is 1.5 million families are living in the US are living on less than $2 a day. I think, and this is a group of people that they call the virtually cashless poor. And they trace this to welfare reform, in which welfare was switched from people getting cash assistance to kind of all these kind of service resources, right? And so I think we need to address the discrepancy between kind of what the healthcare system expects low-income people to be able to do financially and the reality of their financial situations. And we have to recognize that people are cash poor. They do not have cash on hand. So I think that we need to think about that when we're thinking about kind of improving access to care. And then I can't remember your last question. I think you said, is this really a problem? I gave a little bit of evidence that this is not, these strategies are not limited to this community. The doctors I interviewed, again, they're from all over, and they said, yes, I know about this. And then as I've presented my research, I've had so many doctors say, yes, I know my patients do this. So again, I can't speak to the exact prevalence of these, but I think it's much more widespread then we recognize. I do think it's a problem. So yeah, it needs to be addressed.
So here's a related one from Harold Pollack. Which of these challenges might be ameliorated by raising Medicaid reimbursement rates, perhaps pegged to some proportion of Medicare reimbursement rates?
Mm-hmm. That's an interesting question. I mean, I think that would address some of the resource deprivation that I talked about in terms of the professional networks of doctors who work with low-income patients, and this idea that there are doctors who cannot find specialist care for their patients, right? So if Medicaid is reimbursed at higher rates, there will be more specialists, for example, who will take on low-income or Medicaid beneficiaries, and that kind of deprivation won't be as kind of pressing in that way. I think that addresses part of the problem, but I think that there's also just this kind of almost more immediate problem of people just not even being able to enter into the system because of their own personal lack of resources.
And from Nola Wallace, she asked, can you speak on the correlations of your findings to the Latinx population? Do you see similar trends, or what do you see that's different?
Mm-hmm. Yeah, so this is an interesting question. I'm close to the US-Mexico border. So my research on Mexican immigrants is in a totally kind of different context. And what I've found in my research here is that people have this alternative system right across the border, and it's much less expensive. It's much easier to kind of access. There are fewer barriers to access. And so the strategies that people, at least in my own research that I'm discovering, that I'm conducting now, are different. They rely much more on kind of crossing the border to get care, or for people who are not able to cross the border because they're undocumented, having people cross the border for them to go to pharmacies in Mexico, for example, where it's pretty easy to get medication without a prescription. So the set of strategies that I know about, at least, are pretty different, and it's kind of particular to this specific kind of geographic context. Also, I think what we see kind of in the literature more broadly is that among at least kind of first generation immigrants, there's much more kind of use of folk medicines and kind of folk healers than what I saw with the population I studied in this book.
So we have a very distinguished audience who can think very well about how to address some of the issues that you raised. So I strongly encourage all of you to jump in, but I will, in the meantime, ask a second question I had, which if we know about this in our healthcare system, what responsibility does the system have to address some of these issues, to address some of the obstacles? For example, to include transportation in their services, or to understand that people can't get their prescriptions sometimes delivered to their neighborhood because the mail doesn't go there, or they can't walk to the post office. If we try to take a system look at this, what are your thoughts on that?
Mm-hmm. Yeah. So again, I mean, I think there's this discrepancy between what the system expects of low-income people and then kind of the reality of low-income people, and kind of some of the very things that you talked about, transportation, kind of not being able to get to places like pharmacies and so forth. We can see within our system there are some plans and some people who have free transportation to doctors, right? These are people that tend to be people with disabilities. People are able to get their medication sent to their homes, right? So I think that there are actually solutions in there that we can see, but it's an issue of kind of expanding who is eligible for these different programs, right? I think that there's a lot of kind of political hesitancy to help people who are low income and perhaps don't have a disability, right? They want people to have some kind of buy-in, right? To have some responsibility for taking care of their own healthcare, which is, I can see that, but I think that what the study highlights is just how detrimental it is to people when they're not able to be integrated into the healthcare system. And that I think the healthcare costs of not getting care are really going to outweigh kind of the smaller costs it would take to kind of expand access to transportation and so forth.
I agree completely. So Ms. Yunuan Rodriguez says, thanks so much for your talk. You mentioned that doctors are motivated to informally help their clients. Did you at all observe instances that show otherwise? Perhaps instances of bias, discrimination perpetuated by providers toward their clients?
Yeah, I mean, I think there's some selection bias in my sample in that the doctors I spoke with really wanted to kind of talk about their experiences. I think these are people who are kind of much more kind of committed to this population on kind of a moral or kind of ethical level. So I didn't see issues of kind of discrimination and so forth. But within the 17 doctors, among the 17 doctors that I interviewed, 7 of them said, I would interview them. And then at the end, I would say, this is what I'm learning from some other people. What do you think about that? In terms of kind of the strategies that doctors were using. And some of them said, absolutely not. I would never do that. I would never cross that line. And one of the things in the book is I kind of detail the differences between these two groups. And one thing that I say is that there's kind of different notions of duty. People who help their patients in this way kind of have this expansive notion of duty, where they really believe that it's their responsibility to do whatever they possibly can to help each and every one of their patients. And they really spend a lot of time kind of understanding individual patient circumstances, right? And then there's this other set who won't do this, and they kind of say, I know that these problems exist out there, but it's not really my job to fill in these gaps. And so they have a policy that kind of that doesn't open them up as much to individual patient cases, right? They don't let themselves kind of get as emotionally involved with individual cases. So they say, I'll use whatever means are kind of available above board. If I can get samples, or if I can get them into a prescription assistance program, I'll do that. I'll send them to this or that place, but they kind of refuse to break the rules, right? Part of it also is to protect themselves from burnout, right? So they have policies where they kind of emotionally distance themselves from patients. So there's some difference within among the doctors that I interviewed, and that's kind of described in depth in the book.
That's great. And from Rosa Ortiz, you mentioned that filling out the forms for Medicaid can be a problem. What is the literacy in general with the population you studied? And I don't know if you learned anything beyond literacy levels, but also what are the other barriers that you might have identified in terms of gaining access to Medicaid?
Yeah, so in this community, there's a lot of heterogeneity in terms of education levels. There's some people who didn't complete barely any high school. There are other people who actually went on to finish a couple years of college. So there's a lot of variation within there. I think, there were people who were hired from the development specifically to kind of sign people up, right? So I don't think that individual literacy was that much of an issue, because there were these navigators from the community who could kind of help walk them through the process. I think it was more an issue of kind of knowing what paperwork to get together, actually being able to get the paperwork and so forth, right? One obstacle that I found among men specifically is that many men in this development do not legally reside in the development. So they're not on the leases of the unit in which they stay. And this is for a variety of reasons. One being criminal background checks. If you have a criminal record, you can't legally reside in this development. One being kind of income requirements. The more adults on the lease, that could change your income, your income levels could make you less, ineligible. So what this meant is that there's kind of a certain subpopulation within this development that doesn't actually have a legal address. And they're very afraid of kind of giving their private information to healthcare entities or to anybody that's kind of considered, related to the government, right? And so this winds up kind of acting as a barrier to applying for programs like Medicaid, just not having this legal residence. Other people, didn't have state IDs and they haven't had state IDs in years. And then they get in this issue where they don't have a birth certificate, so they can't get their social security card, right? And they can't get the transportation to do each and every one. And it's just kind of barrier after barrier to getting the paperwork together. And that's kind of why they wind up not applying.
Seems like there's a role in there perhaps for a social work program to help people achieve eligibility. Something for us to talk about. I wonder, we have reached the end of our questions. Oh, here's another one. Thank you very much, Frania Mendoza-Lua. Recently, there have been growing reports and concerns in communities about how underground medications and even just prescription ibuprofen you can buy from someone that they're being laced with fentanyl and other drugs. I'm curious how respondents determined who to trust in their communities or determined who had the real medications and if it was a concern at all.
Yeah, it was definitely a concern. And again, this is something I kind of describe quite a bit in the book. So people have kind of a calculation of who to trust in this development. One of the main things they do is they try to go to relatives first, because they feel like, okay, relatives will be kind of forthcoming about what kind of medication they have, or to kind of trusted friends if it's not kind of available through friends and family. Another thing that people do is they have physician desk references or other kind of medical manuals, and they've gotten them from doctors. They've gotten kind of old copies from their doctors. Someone went around selling these in this community for a while. So people were very aware of kind of the risks of buying medication off the street. And they would try to use the physician desk references to identify the pills to make sure it was what the person was actually saying, right? So they're kind of very cognizant of this. Those are some ways that they try to mitigate risk. Another thing that I learned is that most people who face obstacles to care have some experience with the formal healthcare system, right? So at one point, they had an onset of symptoms that they got really nervous about, or kind of, they felt like, okay, I absolutely have to seek care. So they go to a place like the public hospital or the emergency room, right? And they learn information in these experiences. They get a diagnosis, they often get a prescription or kind of some description of a therapy. And what they try and do is take that and then get the needed resources informally, right? So they're applying what they've learned in the formal system to their kind of informal strategies, kind of in an attempt to mitigate risk. So there are a few different things. This is just to say that there's kind of a few different things that people do to kind of minimize the risks of using these strategies.
That's great question and answer. I have one final question that I wonder if you could tell us how you're going to build on this work in your next study. It's such important work.
Yeah, so In this next study, the primary question is a little bit different. I'm looking at this question of kind of how does living in a border region shape people's healthcare practices? But again, what I'm really interested in is kind of looking at how people navigate the healthcare system, right? And what I found is that, there's a lot of research on kind of care at the border among Mexican immigrants. And there's this idea that people kind of go to Mexico to get care because it's cheaper, or because they're uninsured in the US. And so they go to Mexico where they can kind of get healthcare inexpensively. But what I found is that even among people who are kind of integrated into the US system, they're still getting care in Mexico. So a lot of my study participants have health insurance, they have a primary care doctor and so forth. And yet there are still times when they sometimes go to Mexico. And what they're doing is kind of strategically combining health services on either side of the border to try and get what they believe to be the best healthcare results, right? So people will do things like go to the doctor in the US, for example. The doctor doesn't want to refer them to a specialist, so they cross the border to Mexico where they can directly access a specialist without a referral, right? Or they go get care in the US that requires kind of higher levels of technology and go to Mexico for more simple procedures where you don't have to wait in line, for example. It's just kind of a faster experience, right? So there are all of these kinds of ways that they're combining services on both sides of the border. And one of the things that I'm arguing is that this really kind of changes the nature of patienthood, right? So it's a system where people have increased autonomy over their care, and they can kind of act independently of kind of healthcare professionals, right? So that the nature of being a patient, it completely changes in this context. Interestingly, it also, I think, stratifies the Mexican immigrant population in interesting ways, right? So if we think of kind of the ability to get care in Mexico as a benefit, what we see is that it's people who are lawfully present, for example, who can take advantage of this cross-border system, but undocumented people can't. And what I'm finding in the interviews is that very low income people also can't, because they say, if I cross the border, I have to pay for a taxi and I also have to pay for food while I'm there. So I can't afford to do that, right? So this context changes the nature of patienthood, but it also stratifies the Mexican immigrant population. So that's kind of key findings so far.
It's fascinating, really wonderful work. And your findings ring true in so many ways. Melissa Lomelli says, I am also one of those people who are integrated thoroughly in the US, but consult Mexican doctors physically or virtually for better and faster medical care. Thank you for your presentation. We can all join Melissa in thanking you for your presentation, and we look forward to learning your future findings. Thank you, Danielle, and thank you to the audience. And don't forget, we have one more in the fall Michael Davis lecture next Tuesday. Look forward to seeing all of you then. Thank you.
All right, thank you so much.